Back with another session here. Here we'll discuss about the carbohydrate metabolism in pregnancy. So why it is happening, like carbohydrate metabolism changes, why it is there, just to ensure an adequate supply of glucose for the developing fetus for to meet like its growing needs. So mother will provide glucose to the fetus. Fetus is solely dependent on the mother for that glucose, and this glucose is provided via the GLUT1 receptor and GLUT3 receptors, and this type of transfer is known as facilitated diffusion. So whenever there is the diffusion via this receptors, this is known as facilitated diffusion. This changes the carbohydrate metabolism is due to some hormonal shifts. As you all know, the pregnancy is a diabetogenic state. So pregnancy is a diabetogenic state due to this insulin resistance. Due to this insulin resistance, pregnancy is a diabetogenic state, and this insulin resistance is due to influence of like some hormones, maternal hormones, estrogen, progesterone, prolactin and cortisol, and some placental hormones which is HPL and placental growth hormones. If you will ask me the main important hormone among all of these, I will say HPL. Then insulin resistance is maximum at 24 to 28 weeks. Now this insulin resistance is also increased due to the weight gain during pregnancy and increased caloric intake during pregnancy, and all of this will lead to increased glucose in the circulating blood of the mother. So increased circulating blood sugar will lead to preferential shunting of glucose to the growing fetus, because fetus is dependent on the mother for glucose. All the glucose, like most of the glucose, will be provided to the fetus for its growing needs, and will lead to hyperglycemia in the fetus. Also increase accumulation of the fat in the maternal adipose tissues. Now pregnancy is a diabetogenic state, as you all know, as well as there is insulin resistance and hyperinsulinemia also. Insulin resistance maximum between 24 to 28 weeks of pregnancy. Maternal insulin cannot cross the placenta, and fetus starts secreting its own insulin by 12 weeks. These are some known facts which is there. Fetus is dependent on the mother for its glucose. So this glucose requirement is provided by mother, and it is transferred by the facilitated diffusion using GLUT1 and GLUT3 receptors. Now glycosuria. Glycosuria is normal during pregnancy. We'll discuss here why it is normal. But before that, I'll discuss like there is a hyperinsulinemia during pregnancy. Despite of that, there is postprandial hyperglycemia, just to ensure the adequate and sustained supply of glucose to the fetus. So our main aim during pregnancy is to ensure adequate sustained supply of glucose to the fetus. Just to meet that need, body will do certain changes. One is postprandial hyperglycemia, other one is fasting hypoglycemia. No change in the plasma glucagon level, as insulin is changing but no change in the plasma glucagon level. Fasting hypoglycemia in the pregnant women are more prone to the mild fasting hypoglycemia. Maternal utilization of glucose is reduced, that's why. Now effect on the fetal physiology. So because of the increased maternal glucose, maternal hyperglycemia, fetal hyperglycemia is there because of the transfer of the glucose, and because of this transfer, the body of the fetus will react, and there will be hypertrophy and hyperplasia of the beta cell of pancreas, and then this will lead to increased level of insulin. So insulin secretion of the fetus will be increased, and due to this increased insulin secretion, there will be a macrosomia in the fetus, because insulin leads to increased growth of the fetus. This is the Penderson hypothesis that you should know. So Penderson hypothesis is macrosomia due to increased level of insulin in the baby, in the fetus. Now RDS. Why RDS will occur in that diabetic mother fetus? Because of the insulin decreases the surfactant production, so leading to the RDS. And hypoglycemia in the newborn, as the baby is connected to the mother during that life. So after birth, connection between the mother and the child is lost. So this high source of glucose is lost. As it is lost, but insulin levels are high, leading to hypoglycemia in the newborn. Now, the reason of the sudden IOD in the diabetic mother is because of maternal hyperglycemia. There is some changes in the placenta, and due to these hydrophic changes in the placenta, some parts of the placenta is become like non-functional. But baby is macrosomic. But as baby is macrosomic, it needs more oxygen and more supply, but some parts become non-functional. There is disparity in the demand and supply. So due to demand and supply of oxygen problem, there will be hypoxia and leading to sudden IOD. Also, hypertrophic cardiomyopathy seen in the infant of the diabetic mother. Now we'll read about the glycosuria, why it is occurring. So glycosuria is like normal during pregnancy. It is normal during pregnancy, and there is some diurnal variation in this glycosuria. It is because of the increased GFR. So there is increased GFR during pregnancy. GFR is increased, so like glucose, more glucose is load is sent to the renal tubules. But this glucose load is not like properly absorbed because our renal tubule absorption limit is 140. So renal tubules absorption limit, reabsorption limit is 140 mg per dl. But as the glucose is increased, the renal tubules will not absorb and some are excreted, leading to the glycosuria in pregnancy. And as after the food, this glycosuria will be more, and while like waking up just after the bed, it is least in morning. Okay, so now because of the lowering of the renal threshold of the glucose excretion, first point, and second is increase in the GFR delivers an overwhelming glucose load to the renal tubules. Reabsorption, which is normally complete, is thus compromised. There is a loss of 140 mg glucose per day. This is normal and the upper limit, but in pregnancy it is like crossing this limit and thus excretion. There is a diurnal variation in the glycosuria, being least evident in the morning and most evident after the meals. Okay, so thank you. We'll discuss some more questions, more important questions in the ongoing lectures.